So you are live, good to go.
Good evening. I, Amit Arora, on behalf of Intas Pharmaceuticals Limited, Zenith Division, extend a very warm welcome to this first in the series of webinars on practice pearls in hypertension. For today's webinar, we have our course director, Professor J.C. Mohan from New Delhi, and we have an eminent expert panel, Dr. Sadanand Shetty from Mumbai and Dr. Soumitra Ray from Kolkata. We have with us our medical advisor, Dr. Mithilesh Nayak, who is giving us this opportunity to do this webinar. So I hand over the session to Dr. Mithilesh Nayak to take it forward.
Yeah, thank you very much, Amit sir. Namaste, everyone. As we all know that uncontrolled hypertension is major cause for the cardiovascular mortality. And emerging evidence provides us valuable insight with regards to management of hypertension and controlling the cardiovascular mortality. Hence, it is very vital to update our knowledge with regards to hypertension management from the emerging evidence. And to guide us, we are having with us Dr. J.C. Mohan sir. Dr. J.C. Mohan sir is the chairman and head of the cardiology department at Jaipur Golden Hospital, New Delhi. He has published more than 250 research papers in the various index journals. He is the only honorary fellow of the American Society of Echocardiography in India, and currently he is the president of Apex Society for CME in the cardiology. He is also recipient of various awards in the field of cardiology, including the Sujoy B. Roy Gold Medal by the Cardiology Society of India, Surley Award for Best Research Paper by the Cardiology Society of India, and Health Minister Award for the Meritorious Services. So now I request Jagdish Mohan sir to guide us further. Over to you, sir.
Good evening, ladies and gentlemen. Welcome to this first of the series of webinar on hypertension. As you know, hypertension is a major public health problem affecting 1/4 of the entire adult population of the world. And same is true for India. Data, howsoever sketchy, suggests that about 30% of adults in this country have arterial hypertension. Even people in the age group below the age of 25 years, the prevalence of hypertension is 12%. So keeping everything together, we have more than 200 million people with hypertension. And as I said, hypertension is a major public health problem. The population attributable risk of heart failure because of hypertension is close to 50%, a little less in men, a little more in women. But the major issue is that more than half of the stroke mortality related to hypertension, more than 1/4 of the mortality is related of ischemic heart is related to hypertension, and also the fact that direct deaths because of hypertension in this country are about 1.7 million a year. So it is necessary for us to understand as much as we can to treat hypertension, because hypertension is not confined only to physicians, cardiologists, nephrologists, neurologists, or diabetologists. It is something which each of us is going to encounter, because every third patient has hypertension. So I personally thought that we should have discussion on each and every aspect of hypertension which is relevant for clinical practice. So to begin this series of webinars, I thought none other than Dr. Sadanand Shetty will be talking about the critical analysis of the recent hypertension guidelines. Dr. Sadanand Shetty is Chairman and Managing Director of Sadanand Hospital, Sion. He is the Emeritus Professor in D.Y. Patil he is the professor and former head of the department of D.Y. Patil Hospital and University, and he is the president of CSI Mumbai branch and founder of CVD India. I request Dr. Shetty to take us through the critical analysis of hypertension guidelines, including the latest one, which just got published 2 months back, of International Society of Hypertension. We know that there are differences in the guidelines. We also know that there are some differences as far as therapy is concerned, and a critical analysis pertinent to India will be very relevant at this stage. Dr. Shetty, sir.
Thank you, Dr. J.C. Mohan. At the outset, I would like to thank Amit Arora and Intas Pharma for giving this opportunity. And I would also invite Dr. Soumitra also in our company, because all three of us are true good friend, guide, and philosopher for me particularly. So what I'm going to do for the next 15-20 minutes, as Dr. Mohan rightly mentioned, we have many hypertension guidelines. As shown in this particular slide, we have International Society of Hypertension, we have European Society of Cardiology, we have American Heart Association, Hypertension Canada, and our own Indian hypertensive guideline, which is not shown here, but that is another guideline which is important for us. So we are going to critically analyze all these guidelines, and then we will arrive at what could be the right blood pressure regarding diagnosis of hypertension and what should be the right target for us in our real world practice. As Dr. Mohan rightly mentioned, hypertension is one of the most prevalent disease across the world, and so also in India. And also the blood pressure control is very poor. Of course, this also data is equally true for global and more so even for India. If you have to see this slide, and if you have to see between the urban and the rural distribution in awareness, in treatment, and in the control, you see definite difference between the urban and the rural. So also if you have to see different states in India, when the study is done, if you look at these three categories of awareness, treatment, and the control, again you see the different value at different places like Bangalore, Chandigarh, Chennai, Jaipur, and Trivandrum. Now, if you have to see, as Dr. Mohan said in the beginning in introduction, prevalence of hypertension in India, this is in 2017, is almost 30.7. Maybe now it might have gone still further, but that is the magnitude of problem what we are facing. If you have to see this, when you see the urban and the rural difference in the control of blood pressure, so also at the different states, see the control of blood pressure also is significantly, not the one which is desired. Like hardly, say less than 10% in the rural, about 15% in the urban. And if you see the different states, the value of, the figure for the control is different. So we have a huge problem, or the magnitude of problem of hypertension globally, and in particular India, is a major issue. Now, if you have to talk about hypertension in India particularly, what are the special features we have to consider? One is the onset in early life is important. Rural-urban divide in prevalence. Clustering of multiple CV risk factors. Significant seasonal variation of blood pressure. Rising average BP of general population, and the low awareness, treatment, and control, which I showed in the earlier slide, and the early hypertension mediated organ dysfunction, possibly due to poor control. Again, the highlighting the point that we have to diagnose hypertension very early in life, because the cumulative effect of hypertension over time is very, very dangerous for the individual. Now, this cumulative subject is important for hypertension, diabetes, lipid. So if you have to look into all guidelines, they mention beyond age of 18 years as one of the cutoff for hypertension guideline, whereas in children or younger age, we don't have. But it is a high time that we need to have some data in the early part of the life, so that we have some, the definite figure of the hypertension or the blood pressure level to say this individual is hypertensive or not. Other important the coexistence in our country, this one study, a study called SIDE, which is the study of screening India's twin epidemic, that is both hypertension and diabetes together. And if you see that particular SIDE study, which is done almost reported in 2012, gives us a prevalence of two diseases together is about 21%. So in the previous slide, I mentioned 30.7% prevalence of hypertension in India as on 2017. Now, if you see two things together, that is diabetes and hypertension, is almost to the tune of about 21%. So this is the magnitude of our problem, hypertension alone, then hypertension with the diabetes. Now, if you look at a study which is done in a diabetic patient, where patient has a diabetes, and then they looked into various risk factors in those individuals, whether hypertension, dyslipidemia, isolated hypertension, isolated dyslipidemia. This, if you put together, lipid abnormality in hypertension, what is called the lipid tension, it is almost 42.4%. So lipid tension is a rising epidemic in newly diagnosed type 2 diabetes, and lipid tension in the background of diabetes require careful attention to reduce cardiovascular events. So again, highlighting, when you diagnose hypertension, also we have to look for one, diabetes is there or not, and in addition to diabetes, lipid abnormality, because unless you take care of all the risk factors, the morbidity and mortality of this illness will not be sufficient. If you have to see uncontrolled high blood pressure and what is the cardiovascular mortality risk, now we take as 115 upon 75 as one-fold risk, and this is done according to the meta-analysis of 61 prospective observational study, almost 10 lakh adults between 40 to 69, and the BP more than 115 by 75. And these results indicate that both systolic and diastolic were strongly related to vascular mortality in middle and the old age. Like if every rise of 20 by 10, the risk doubles. Like if you see 115 by 75, if you see addition of 20 systolic, addition of 10 diastolic, twofold mortality increase. So also here fourfold, eightfold. So simply it gives you idea that risk of cardiovascular mortality doubles with every rise of the blood pressure of 20 by 10, and that is again another important thing for us to know why we need to control the blood pressure in the correct or the target level. Now let us see what new guidelines says. And if you see, there are the areas, principal areas of agreement in various guidelines. So here there is no dispute between any guideline, and which are the standard one, like emphasis on accuracy of BP measurement is important, because in hypertension diagnosis, everything depends upon the blood pressure measurement. So that has to be accurate before saying an individual hypertensive or not. Second most important thing is the cardiovascular risk assessment to determine BP treatment thresholds. And the third thing is a lifestyle modification recommendation, and then maybe initial combination therapy, as is very, very popular after the European Society, the ESC guideline, and even the Canadian guideline, etc. So these are the areas where there is no disagreement. More or less, it is the concordance between all the guidelines. Now let us look into the guideline in these four top heading. One is in the classification, what is the difference? What is the difference in the threshold for treatment initiation? What is the difference in the treatment goal and in the treatment strategy? Now let us come to the classification. We know that when ACC-AHA guideline came in 2017, and then now global, International Society of Hypertension 2020, the recommendation, the classification of blood pressure, like a normal, elevated, stage 1 or 2, and the class 1, and the level of the class of recommendation is 1, and the level of evidence is B, non-randomized. And if you look at the ESC, again class 1C, which is an expert opinion. And if you look at the category of blood pressure in adults, if you have to see the major difference between the ESC and the AHA 2017 is one, normal blood pressure category is same in both the guidelines. That is, considered as less than 129 or 120 to 129 is a systolic, and diastolic 80 to 85. So also it is like here, less than 120, 80. So normal blood pressure category more or less same in both the guidelines, but ESC guideline categorizes grade 1 hypertension when the systolic blood pressure is more than 140 to 59 and diastolic 90 to 99. Whereas if you look at the AHA ACC, it considers stage 1 between 130 to 139 and 80 to 89. So that is the difference. And so also if you have to see only 2 stages in AHA hypertension guideline, whereas if you see ESC, there are three grading, 1, 2, 3, etc. So this is a major difference. That means the stage 1 of ACC 2017 guideline is 130 to 113 systolic and 80 to 89 diastolic, and more than that comes in the stage 2. Whereas in ESC, stage 1 is between 140 to 159, grade 1, and 90 to 95, 99 rather, is the grade 1 diastolic reading. If you have to look at 2020 International Society of Hypertension Global Hypertension Practice Guideline, again is more in like a ESC guideline, where less than 140 or between 130 to 139 and 85 to 89 is considered as a high normal, and less than 130 and less than 85 is considered as a normal blood pressure. And it has gone according to the hypertension what ESC, except that there is only 2 grades. There is a grade 1 and grade 2. Unlike the ESC, which has put grade 3. So that is the difference between the recent, May 2020. Now, if you have to look at the Indian guideline on hypertension 2019, has again gone more in like ESC guideline. If you look at here, high normal is between 130 to 139, 85 to 89. So stage 1, 2, 3, like what ESC has said, grade 1, 2, 3. And this is what is, the typical what we have in Indian guideline. Of course, isolated we say when diastolic is less than 90, otherwise systolic is more or less the same, like, your regular hypertension or a diastolic hypertension. That is what, like a isolated systolic hypertension is diagnosed on this particular grading 1 and 2. So normal is less than 130 and less than 85 is the Indian guideline. Now, according to the clinic and ambulatory and the home BP level, there is a slight difference. We said, in office BP, more than 140, more than 90 for grade 1 of ESC. And for us, the here it is though mentioned more than 140, more than 190, which is not true because the stage 1 is more than 130 and more than, like 80. So this is a little bit different here. Whereas if you look at the ambulatory, between the daytime and the home BP, more or less same, 135, 85. Whereas when you see the 24-hour mean ambulatory about 130, 80. Whereas if you go by the nighttime mean is about 120, 70. So we need to identify the ambulatory BP measurement, various time, and then accordingly we can make a diagnosis of hypertension. Canadian hypertension guideline, again, like when you see an elevated BP reading, office, home, or pharmacy, dedicated office visit, if it's very high, is straight away, yes, it is hypertension. And if you see the out of measurement BP, if it's a daytime more than ambulatory BP preferred, if the daytime is more than 135, 80, 85 and 24 mean more than 130, 80, or home BP is more than 135, 80, 35 by 85 is a state of hypertension. Whereas if the reading is, whether patients are diabetes or no diabetes, and if there is, the automated office BP is more than equal to 135 by 85 or non-AO BP, there is an automated office BP more than 140 by 90, that means you make a diagnosis of hypertension. If it is not, then there is no hypertension. So this is what is the Canadian, hypertension Canada guideline. So when you have to summarize in the diagnosis of hypertension, it's very clear that ACC-AHA guideline hypertension diagnosis set is BP is equal to more than 130 or more than equal to 130 by 80, whereas more than 140 by 90 in the other international guidelines. So this is a clear-cut difference. among all the guidelines put together versus the ACC. However, high risk group in all the guidelines suggest equal to or more than 130 systolic and more than 80, which are the high risk group, which we will discuss in the course of time. Now let us come to the threshold for treatment initiation. Now if you look at the threshold for treatment initiation, again important based on the level of blood pressure, and you make it high normal, grade 1, grade 2, grade 3 as in ESC, whereas in AHA it is the stages like high normal, elevated, stage 1 and stage 2. Again, depending on how to, what threshold we should do, and then also what therapy, etc., depending on lifestyle as well as considering the drug treatment. That again we will discuss in the course of time. Hypertension in Canada, again based on threshold based on patient is in low risk or high risk, or whether patient got diabetes. Rest all comes in all other group, which is, again, the threshold is like a low risk, the threshold more than 160, 100, high risk more than 130, diabetes more than 130, and all others more than 140, 90. And the BP target low risk 140, 90. If it's a high risk, particularly with a cardiovascular disease, less than 120. If it's a diabetes, 130, 80. And all others, 140 by 90 is the target, what is according to the Canadian Hypertension Canada. If you have to look at Indian guideline hypertension 4, that is in 2019, when you have age less than 65 years, high risk ACVD risk or a low ACVD risk. Threshold to start is 140 by 90. Between age of 65, 80, 140, 90. More than 80, 140 to 50 and 90. That is a threshold. With the other risk factor, the threshold should be little low, like diabetes, history of stroke, chronic kidney disease. Whereas a coronary artery disease and heart failure, the threshold to start treatment is 130, 80. So here again, management of hypertension, initiation of a treatment is about 2 to 3 weeks of lifestyle modification. Then the blood pressure, the medication pharmacotherapy, whether single drug or 2 drug, again depending upon any evidence of hypertension mediated organ damage or a target organ damage, and so on. That part we will see in the next discussion. So when you come to the summary of the BP threshold for treatment initiation of all the guidelines is very simple. One, it based on the CV risk factor, and that is the most important the thing which you have to consider. And other thing is possibly, of course, CV risk factors include diabetes, etc. And the BP threshold for the general population is more than 140, 90, whereas a high risk population like the cardiovascular disease or a CAD or patient of diabetes, heart failure, it is about 130, 80. So it's very clear the threshold for therapy. Now let us go to the treatment goal. What is the treatment goal in again according to the ESA, AHA and ESC the guideline? If you look at age less than 65, ESC 120 to 130 less than 80, and so also AHA is less than 130, 80. More than 65 up to 140, 80 we can go, whereas in case of AHA it is still mentioned less than 130. So if you have to see the AHA, whether age is equal to or more than 65, whether diabetes, CAD, CKD, post-stroke, it has made a very easy way of giving it BP goal of less than 130, 80. Whereas with the ESC, it has gone less than 65 age, maybe 120 to 130, 80. And if a patient has a stroke, 120 to 80 or so, CKD 130, 40, 130 to 40, less than 80, and so also diabetes and CAD 130, 80. So there is a slight difference in the figure by 5 to 10, whereas AHA has simplified for every individual, it is 130, 80. And if you look at the hypertension guideline in the US and the Canada, again it highlights a very simple thing. Again, BP target is more or less in hypertension Canada, particularly when you've got a clinical CVD or a high risk cardiovascular disease, they've gone to less than 120 systolic, and they also included Framingham risk score of more than 15%, 10 years, again less than 120. Or if a patient has a CKD, again less than 120. And if a patient is more than or equal to 75 and has got clinical CVD or high risk, again, 120. Rest all are more or less, in par with the AHA, ACC. So this is the only difference between, the Hypertension Canada and the other guidelines. So BP pressure level threshold, if you have to see the Indian guideline, high atherosclerotic cardiovascular disease less than 65 is between 120, 130 and 70 to 80, like, like a ESC and also Hypertension Canada. And if you see the coronary artery disease 120 to 30, 70 to 80, heart failure 120 to 130 and 70 to 80, again given as very clear message that the target is between 120 to 30 and 70 to 80 diastolic in all high-risk ASCVD, in coronary artery disease, and in heart failure. Now, recently, the International Society of Hypertension 2020 practice guideline has said target BP reduction is by at least 20 by 10, if ideally it is less than 140 by 90. That is what they have suggested. It is important for us to control the blood pressure within 3 months after the diagnosis, and less than 65 years, BP target 130/80, and if tolerated, even up to 120/70. So this is important. This is what ESC in 2018 gave us a clear-cut message that the systolic should not come down less than 120 and the diastolic should not come down to 70. And that is to some extent reiterated by recent 2020 International Society of Hypertension, that more than 120/70, less than 130/80. So this is 70 to 80 and 120 to 130 in less than 65, and more than 65, 140 to 90. But again, we can individualize here, because even an elderly, if he's a well kept elderly person, even getting the lower level is okay. So also a patient is very frail, patient cannot tolerate the BP of even 140/90, even little higher BP level, even up to 150 to 90, what is called as a tolerable BP for a particular age, we can individualize. So what is the summary of the blood pressure target, cardiovascular risk factors, and the age should be considered while targeting the blood pressure? Less than 140/90 for all the population, and less than 130/80 very clearly for high risk or established ACVD, coronary artery disease, heart failure, less than 130 to 80, but more than 120 to 70. So 120 to 70, 130 and 70 to 80. Now let us come to the treatment strategy. Now treatment strategy, again, drug treatment, we know maybe during our discussion we can discuss on that. The standard DSC is either ACE inhibitor or ARB, plus the combination of either CCB or a diuretic, ideally thiazide-like diuretic like chlorthalidone or indapamide. So one of the combination. If still step 2, maybe we can add one of these plus CCB and diuretic. If still resistant, small dose of spironolactone. And beta blocker is one thing which ESC is suggested if there is the indication specific like heart failure, etc., or younger woman or younger individual with a high sympathetic drive. And in our Indian people, even the recent India Heart study has shown that we have high sympathetic drive, and so it's an important drug, particularly for an younger individual. And if you look at the AHA, ACC also, again 4 drugs are recommended. There is no mention of beta blocker here, but again, in a select indication, if there is a compelling indication, maybe you can give, but in uncomplicated, there is no mention of beta blocker. Now, Canada 2020 and the ISH also 2020, more or less the same drug recommendation. Only thing in Canadian classification, beta blocker can be used safely as a first-line therapy in younger patient only with the uncomplicated hypertension. This is a point I want to highlight, particularly for a young Indian hypertensive, because young Indian hypertensive has a lot of hypertension with lot of sympathetic drive. We must know that elderly people are volume-related hypertension, so diuretic and CCB are the drug of choice. Middle-aged or so more like a renin hypertension, and younger people are more like neurogenic hypertension, which is due to the sympathetic overactivity. And we know that beta blocker is an important drug, particularly the newer beta blocker, like nebuliol like molecule. So beta blocker is an important drug, even single drug, or maybe in combination. Uncomplicated hypertension is a drug for our population. So other important thing what we should know, that the single pill combination should be considered, because basically we have to see the treatment adherence, treatment efficacy, efficiency and tolerability, and any synergistic single pill combination is a better way of approaching hypertension, because hypertension is a relatively asymptomatic disease and the drug should not give the side effects, as well as proper adherence to the therapy is the key. That patient should be taking therapy all the time, and therefore current recommendation by all the guidelines is a single pill combination which includes multiple, and particularly for us in India, we are better off because our pharma industry is so good for us, that single drug, single pill, two drug combination, three drug combination, and a good synergistic combinations are available to us. So this is what is the Indian guideline 2019 tells us. Younger individual where beta blockers are preferred, and the beta blockers like drug like newer beta blocker which has got high selectivity, beta 1 selectivity, and they have nitric oxide donor like drug like nebivolol, etc., are important drugs particularly for a young hypertension. And plus combination therapy is important, etc. So if I to summarize what is the treatment strategy as shown by all the guidelines, are these following things: that 5 classes of drugs, ACE inhibitor, ARBs, calcium channel blocker, diuretics and never beta blocker, combination therapy of different class of drugs with different mechanism of action, so that the effective control of blood pressure with a minimal side effects. And younger individual have a high renin hypertension, and hence maybe RAS blocker like ACE inhibitor, ARB, or newer beta blockers are preferred. This is a very important take-home message, I would say, that in our younger hypertensives, we have to consider newer beta blocker either in single or in combination, while older individuals have, as I mentioned, low renin hypertension, so diuretic or CCB are the therapy of choice. So just come to the last 1 or 2 slides. Now, when I discuss for last 15-20 minutes on this guideline, what are the the concluding the remarks we get? The guidelines are little divergent yet convergent. What way they are divergent? Regarding the definition of hypertension. Like American says more than 130/80 as hypertension, whereas European and then the other like Canadian, even Indian, and even the global now in the International Society of Hypertension current one, all said hypertension definition more than 140/90. But so it is a divergent in that way. But when it comes to the therapy, it is convergent. That means the treatment goal should be the same, that is less than 130/80. So just to summarize my talk, what we need at this point is the agreement between the guideline. More agreement we require, and that is what is there. Then the major difference, all guidelines strongly recommending lowering BP target for high risk patient, and this is very, very important, particularly for Indian patient. As I showed in the beginning of my presentation, how hypertension, diabetes is together, how hypertension, diabetes, dyslipidemia, common risk factor in many patients. So we need to see that lower targets are recommended for our high risk patient, and we need a proper PP measurements, laboratory and diagnostic testing, lifestyle behavior changes and pharmacological management. Newer threshold to diagnose and treating hypertension are especially relevant in India, particularly high risk population. We are high risk population. I would consider that India, particularly younger people, have got high risk, the risk factors, and therefore we need to to keep a threshold of almost 130, 80 or so. However, in a low risk population, more than 140 or 140/90 threshold, for more than 140/90 as a threshold, and maybe the target about 140/90. The aggressive BP goal may be difficult to achieve in all Indians, but we must as a medical community take a concerted efforts to embrace this recommendation. With this, I would end my talk. Thank you very much for the patient hearing.
Thank you, Sadanand. That was an exhaustive and comprehensive critical analysis of the guidelines from 2017 to 2020. And there are actually 7 questions for you, but we would take those questions at the end of Dr. Sumitra Ray's presentation. But you know, the kind of guidelines you presented, and of course, here and there, the differences reminds me of an anecdote. You know, now I never told anybody this anecdote, but now that Mrs. Mohan is dead, I don't see any reason why I cannot tell you. So 50 years back, when I was a young medical student, a girlfriend of mine actually gave me a birthday card. The birthday card said, "Let me kill you with love and love only." And I would like to send you a birthday card saying, "Let me kill you with guidelines and guidelines only."
Yeah.
So we will move forward. We'll go to Dr. Sumitra Ray's presentation, and then we are going to have the discussion. So my close friend, Dr. Sumitra Ray, is a consultant intervention cardiologist. He's a director of invasive cardiology in AMRI Hospital. He's a professor of cardiology in Vivekananda Institute of Medical Sciences, and of course, an EC member of CSI, and one of the most accomplished cardiologists I have come across. I actually, when I think of Kolkata, I think of cardiology, I only think of Sumitra Ray. Dr. Ray, the floor is yours.
Thank you, sir. It's such a nice compliment from such a person like you. All my pranams to you. Thanks to all of you and the Intas company as well. Now to make a preliminary background for my talk. Now, as Dr. Sadanand Sethi has elaborated, Dr. Mohan has said, worldwide, hypertension awareness is around 30 to 50%. In India, 30%. Treatment is of that 30%, another 30%. And control is of that treated another 30%. So it comes to around 5% to 10% of the whole hypertensive population who is controlled. And have you ever thought why? What does it require to check blood pressure? You don't require a doctor, you don't require even a nurse. Your family member can check your blood pressure. It doesn't require a prick, no blood test, no cost. So why this 5 to 10% of treatment control? I was thinking, I thought one of the causes is that that blood pressure is boring. It's very boring. How many cases of transposition of great arteries or neurofibromatosis type 2 is missed in the community? Not a single case is missed. But blood pressure is missed in 95 out of 100 people because it is boring. So when the opportunity came, Dr. Mohan gave me to present an unusual case of hypertension. I thought, let's learn by fun. So make hypertension funny, though it is a boring subject. So let's go to the slides, sir. Who is showing the slide for me? Dr. Nayak, are you showing the slides for me? Yes. So an unusual case of hypertension. Next, please. Now, my friends, I will request you to go through each and every word very carefully, because history is very important. He's a 50 years old man, corporate executive, divorced, living alone, smoker of 10 a day, socially takes alcohol, an irregular eating habit. Symptoms are long-term fatigue and feeling low, mild shortness of breath. He is medium build, weight is 66, BMI is 23.5 on the leaner side, waist circumference 35 inches, pulse is 70, regular and equal, BP is 160 by 90, both arms, sitting, no postural change, equal in limbs. He came for a corporate checkup, annual corporate checkup. Next. There's mild pitting ankle edema, JBP is normal. CVS, gastrointestinal, genitourinary, neurology, all normal. Only respiratory showed mild wheezing because of his smoking habit. Now, guideline, I was killed by guidelines. So I went to the guideline. What to do with such a person? ESC says you do the baseline investigation initiated for hypertension. And I followed the table toto. His full blood count was normal. His fasting sugar was 88 with HbA1c of 6.1. Cholesterol profile shows LDL 102 and triglyceride 212. Sodium, potassium normal. Creatinine was borderline 1.3 with eGFR 80. Uric acid was 6.2. Everything was mentioned in the table on your left. So I just followed the table. LFT was normal. Urine routine was normal. ECG showed sinus rhythm with left ventricular hypertrophy. And echo, though not mentioned in the left panel, it was in the next slide in the ESC, but I have incorporated here, showing left ventricular hypertrophy mild with grade 1 LV diastolic dysfunction. So that was my initial finding. Next, please. So what do I do for management? As you might say that he should have lifestyle advice. Of course, you would have. You have diet advice, exercise advice. Should I start pharmacotherapy? I started. You know why? On the first visit. Because BP was grade 2, not grade 1. There was evidence of target organ damage. There was LVH. There was albuminuria, mild. Pharmacotherapy started with lifestyle management. And again, I am fond of Europe. So I went to Europe to get the fixed dose combination of telmisartan 40 and clothianidone 12.5. You don't blame me. That is the commonest combination in India for whatever reasons. I am a common cardiologist. So I started with telmisartan 40 with clothianidone 12.5. At 6 weeks follow-up, BP was still 152/90. So I again went to Europe and found that the third drug has to be a calcium channel blocker like amlodipine in a fixed dose combination. So I added amlodipine 5 in the fixed dose combination. Another 6 weeks passed and the BP was still 146/84. He's still hypertensive. What next? Next. Now he is a case of resistant hypertension, isn't it? By definition. What is the definition of resistant hypertension? When optimum or adequate dose of 3 antihypertensive, including 1 diuretic, is given, and still the blood pressure is not within your target. So he now qualifies to be stamped as a resistant hypertension. Now, whenever I talk about resistant hypertension, I must see whether it is a pseudo-resistant hypertension or true resistant hypertension. Now, risk of MI, stroke, end-stage renal disease, and death in adult with resistant hypertension is 2 to 6 times more. So I have to be very careful now at this stage after 3 months of my initial consultation. The evaluation of resistant hypertension involves consideration of many patient characteristics. Whether I'm talking about pseudo-resistance, my technique is faulty. I'm not doing in a sprint manner. White coat hypertension, I must do a BPM, or medication compliance, whether the patient is taking, and screening for secondary cause. So I did an ABPM and confirmed there was uncontrolled hypertension and all the other causes of pseudo-resistance I excluded. He's a very intelligent, motivated corporate executive. He is conscious about his health. So I don't think there was any fault in taking medicine or compliance problem. So as I said, resistant hypertension is defined by all international bodies by the same definition. The inadequate control of BP has been confirmed by ABPM or HBM. I have done it. So I am now calling it a true resistant hypertension. After exclusion of various, please go back. After exclusion of various causes of pseudo-resistant hypertension and secondary hypertension. Now, what are the secondary hypertension? Next, please. Now, key step for secondary hypertension, which I missed in physical examination. So I thought, have I missed anything in my examination? Skin inspection, have I missed cafe au lait spot for neurofibroma? I again saw there was no cafe au lait spot. Did I fail to palpate the kidney for renal enlargement or polycystic kidney? No, I didn't. Did I fail to hear the heart or renal artery bruit or murmur indicating of coarctation or renovascular? I cross-checked, I rechecked, and there was no such thing. I compared the radial and femoral pulses for any delay, maybe autoarteritis, maybe aortic coarctation, maybe any other kind of connective tissue disease. No, I did not miss anything. Signs of Cushing or acromegaly, I stared at the patient hardly for 5 seconds. Really, no, nothing, no clue. Signs of thyroid disease, no clue. Next. Any clue for secondary hypertension? Even if I miss something in physical examination, CKD, ultrasound was normal. Renovascular, renal artery Doppler I did was normal. Endocrine, thyroid I did. Electrolyte, sodium, potassium, calcium, magnesium, normal. Coarctation of aorta, no physical sign. Chest X-ray, echo was okay. Obstructive sleep apnea, he was not obese, rather he was on the thinner side, 23.5. And if you see the common causes of secondary hypertension in an adult, obstructive sleep apnea. Am I missing? Not really. Renal parenchymal disease, I have said. Renovascular disease, not really. Endocrine common causes. No, I cannot do all the hormone assays, but the most important clue is sodium, potassium before the treatment is started. And the patient had sodium, potassium when he was not on any antihypertensive medicine, and they were normal. So I do not suspect anything related to adrenal or adrenal gland related. Coarctation, as I said. Next, please. Am I missing any corroborative drugs which the patient is taking surreptitiously? Let's recapitulate the drugs. Oral contraceptive is a man not taking it, obviously. Diet pills is not taking because he's thin. Nasal decongestant, he said no, he was not taking any Otrivin. Stimulant drug, no, he denied. Licorice, immunosuppressant, anti-angiogenic cancer drugs, an anabolic steroid, erythropoietin, not really, no painkiller, and not even any homeopathic drug. You know, homeopathic drugs may contain sometimes unlabeled drugs, contain various things like steroid. And like some health fanatics take Chinese herbs like Ma Huang, ephedra. He was not like that. So I was really clueless. Next, please. And some rare genetic causes, which I do not bother you. Just I'll say, if you see that in the phenotype, almost everybody has got either hypo or hyperkalemia. So if your potassium is normal to start with, when the patient is not on any medicine, you can reasonably exclude without going into genetic study most of these. His potassium. So this is very important. Before you start medicine for blood pressure, you check the baseline sodium potassium, because in future it will be very difficult to check sodium potassium if you suspect any of these genetic or endocrine causes. So this is a warning, my friends. Next, please. And I went across the Atlantic to see if I am missing something from America, because I was sticking to Europe, and I found nothing new in America. They just copied whatever they are in the Europe, because they are in a part of Europe anyway. They are new Europe, so they didn't change anything. Next, please. So the common causes by America, again, renal parenchymal disease, renovascular disease, primary aldosteronism, obstructive sleep apnea, drug or alcohol. So what did I miss, my friends? Next, please. Now go one step at a time. Next. Stop. Being clueless, the patient was admitted to hospital for observation. Next. That night, nobody in the ward could sleep except the patient. Next. He was snoring like a giant. I got a phone call in the middle of the night. Your patient is disturbing everybody. I said, why? Is a hooligan or what? No, he's snoring. I said, at least he's sleeping. That's great. Next. Following night, I arranged for a polysomnogram. Next. There was an obvious case of obstructive sleep apnea. Next. I started CPAP in the hospital, trained the patient. Next. BP was 136/80, only on amlodipine and telmisartan. I stopped the diuretic after 1 month and he was happy again. Next, please. So why was it missed in the first place? Why did I miss it? I had a soul searching. Next, please. The reason is that I was under the impression that obstructive sleep apnea occurred only in obese people. That was my greatest blunder. Next, please. My patient was 23.5 BMI. Next, please. Waist was 35. Very handsome looking guy. But if you see the obstructive sleep apnea of the whole boxes, only one left box says body mass index. So it is only one parameter, my friend, to determine obstructive sleep apnea. What are the others? Large neck size. Did I measure? No. Who measures? Only the tailors measure. Genetics, gender, aging, race, endocrine, alcohol, smoking, medicine, menopause, abnormality of head and neck. What did I see of these? I was sticking to body mass index. Next. And you know that type of sleep apnea can be obstructive or central or a mixture. Obstructive is the commonest type in which the airway has become narrowed, blocked, or floppy. Next, please. How is it diagnosed? Next. It depends on a complete history and physical examination. What did I miss and what did I overlook? See, what are the symptoms written in the book? Daytime drowsiness and lack of clarity in the morning. My patient said fatigue. We can equate, can't we? Headache, not there. Forgetfulness, not there. Worsening depression. He said he was feeling low. Yes. Poor job performance, not there. Loss of interest in sex. He was divorced. How could you assess? Leg edema, it was there. Snoring. Now it is very interesting. Snoring is the symptom. And it was undetected initially because he was living alone. Who complains of snoring? It is your spouse who complains of snoring. Your children complain of snoring. When you are living alone in a posh flat, who will complain of your snoring? That's why I missed, my friends. There I made the blunder. Of the signs, what did I miss? Obesity, but only 70%. In some studies, they say 50% are non-obese. I was under the wrong impression even at the age of 56 that sleep apnea occurs in obese. Children with large, he was not child. Collar size more than 17 inches for men. Now I measured his collar size in the hospital and it was 19 inches. I missed it. I missed it. He was in suit and tie. I never looked at his neck. And he had a large tongue. Now I detected. Now the first time I asked him to open your mouth and show me your tongue. I never did it. Retrognathia, which was not there. Narrow palate, which was not there. So I missed 3 physical signs. Next, please. Now it goes from snoring to apnea to morbidity to early death. That we all know. Next, please. And you know how to do it? What is this AHI? Apnea Hypopnea Index. How many spells of apnea or hypopnea you have in 1 hour during sleep study? If it is 0, say you die 1 time. If it is 0 to 5, you die 1.5 times. If it is 5 to 15, you die 3 times. If it is more than 15, you die 16 times. So much is important is the apnea hypopnea index by polysomnogram. Next, please. So that what we do, we can have a limited polysomnogram, we can have an extensive, we do EEG, electrooculogram, EMG, EKG, and ABG. And we see, next please. In my patient, everything was wrong. Everything was wrong, and he was a frank, florid case of obstructive sleep apnea affecting all the parameters. Next, please. So the treatment, very simply, still weight loss. Those 50% or 70% people who are overweight, their weight loss helps, not in my patient. Nasal decongestant. Now you give Otrivin. You are scared of Otrivin that it might cause hypertension. Now you are giving Otrivin because it will reduce blood pressure. CPAP is the treatment of choice. Those people, some people might require a BiPAP, and positional therapy. Maybe you prone position sleeping. Nowadays with COVID era, you are advocating prone sleeping. Now this is another indication for prone position sleeping. Next, please. And I am not going into that. There are certain parameters. If you're interested, you can read it. Epworth scoring, quick sleep study, and the PAP titration. AHI is most important, apnea hypopnea index. How many times in an hour? And next, please. And with body weight, those who are overweight, they really gain a lot of AHI index from -20 to +20%. So it's really a major impact. If you are overweight, you are lucky. You have got a good treatment. Next, please. And with CPAP, also you have got a huge reduction of systolic and diastolic pressure by 10 millimeter each easily. So you can get rid of one antihypertensive medicine straight away. Next, please. And there are certain surgeries. I'm not going into that. You are all physicians here. Some ENT surgery, some cosmetic surgery, tracheostomy, UPPP, etc., and bariatric surgery in those morbidly overweight. Next, please. So my last slide, the 10 OSA commandment. Prevention, help to avoid overweight and obesity. Diagnosis, because we are taught so much of this overweight and obesity, that's why I was brainwashed. Diagnosis, suspect OSA in case of snoring. So you may admit the patient just to diagnose snoring. Reason for admission, to detect snoring. Confirm the diagnosis, do the polysomnogram, quantify the sleepiness, identify comorbidity, explore the upper airway by a good ENT surgeon, establish a program to reduce weight, start treatment, supervise the correct use of CPAP, and establish a follow-up plan. That is your 10 commandments to deal with a patient of OSA. Next, please. So, summary, my friends, OSA is one of the commonest cause of true resistant hypertension. It tops the chart in America and within the first 5 causes in Europe. And we Indians are more. We are centrally obese with short neck. So we are more prone for obstructive sleep apnea, and we smoke like pipes. It may occur in non-obese patients. Most important learning point for me, high index of suspicion is needed. Clues may be found from history and physical examination, but we need to know what are the clues. Polysomnogram is diagnostic. Treatment is effective in symptom and hypertension, but may not affect longevity. There is a query mark whether you can really reduce sudden cardiac death or longevity by giving CPAP. There are conflicting results about it. I think that is my last slide, and thank you to all.
Thank you, Professor Soumitra Ray. That was a iconoclastic case. And I think each of us must be having 1 or 2 iconoclastic cases in our treasure. I remember having presented once in CSI a similar kind of guy, 60 years or 58 years, who would actually, I did every single investigation, but all right. So what I admitted the patient, same drug, his blood pressure was beautifully controlled. So what was happening was that these were 2 brothers actually, who were actually running a business, and they had offices, side by side offices. And this gentleman was a younger brother, So what will he do is that in the evening before going to home, because they were also in a joint family, he couldn't drink at home. He would take 3 or 4 packs in quick succession every evening and then go home and have dinner and sleep. So when we admitted him, he had no alcohol, and lo and behold, the blood pressure fell actually right next day onward, the blood pressure was normal. I mean, so that was an iconic case, and you rightly presented another case. Thank you very much. The only thing I want to make a comment before we come to questions and answers, which are plentiful. Despite you showing a dramatic reduction of 10 millimeter in systolic blood pressure, Hyperco, which is a multicentric randomized Spanish trial of CPAP in resistant hypertension, showed only a 3 millimeter fall in systolic blood pressure. Hyperco is the only study available, multicentric, randomized, and so I'm actually, but it converts non-dippers to dippers in 50%. So the risk decreases, risk of everything decreases. But when you talk of systolic blood pressure, there were average 3 millimeter fall. But we know cases like you have got where the blood pressure fall has been significant like you have got. So you are right, but I'm just talking about the bare facts of life. Bare facts are that the only trial available doesn't say that causes much fall in blood pressure, but you are absolutely right. Now, I will ask Dr. Sadanand Shetty if he wants to make a comment on your case, and then we'll go to Q&A. Dr. Shetty, please.
No, I agree with Dr. Mohan. And of course, as you mentioned, Dr. Soumitra, he's one of our highly accomplished cardiologists. It's a very good, the case, how we, describe the case. Like, the point is how you miss and how you learn from the case, like that. So it's I would say a typical, like a classroom teaching for a postgraduate, like, this is the case, and how, at the end, he has given a very clear-cut answer that the index of suspicion should be kept, like many times, like common causes, we have to keep it in mind, and then index of suspicion can rule out. So, I would say this is excellent case presentation, and I would agree with him. Our sleep-related issue as a cause of, like a resistance or a difficult to control hypertension, we have to keep it in mind. Yeah, I agree with the case. Yeah.
So let's go to question and answers. One gentleman asked us a specific question, and that is a fixed drug combination of ARB plus beta blocker as an antihypertensive. How rational is the combination? And I will ask both of you to respond. First, Dr. Shetty, and then Soumitra. ARB plus beta blocker for management of hypertension. How rational is the combination? That is the question.
So, first, let us talk about the compel indication. There is no any discussion comes. Compel indication means patient of established heart failure and all, where you got an indication for a RAS blocker and beta blocker. That is fine. Now, if I have to talk about uncomplicated hypertension, how this combination of the beta blocker and say RAS blocker, say maybe any sartan is synergistic, because as I mentioned, in young hypertension it is a neurogenic and maybe to that extent renin hypertension. So if you have to look into beta blocker alone for a renin hypertension, it does have a little effect on reducing the renin level because of the sympathetic the blocking effect, but a synergistic, in fact, in a young hypertensive, we do give quite a bit when beta blocker alone doesn't control, and it is not a volume mediated, and there is no compelling indication for other reason. I am saying uncomplicated hypertension, difficult to control in a young hypertensive. After the beta blocker, there is a place to put on. See, among the A's or ARB, our always choice is ARB. Because of the incidence of cough and etc. Because as I mentioned during my talk, we don't want to produce any symptoms due to drug, because patient is asymptomatic. Now you give drug-related problem, patient won't adhere to the therapy. Therefore, ARB is like a long-acting, either telmisartan or maybe any sartan, longer-acting, is a synergistic with a beta blocker, both catecholamine beta blocker and renin is RAS ARBs, that is either one of the statin, long acting. This is one combination. If I had to get the blood pressure more than 20/10, I would put an young hypertensive. Whereas a compelling indication is a standard, like, post ISD or secondary prevention, RAS blocker, beta blocker, antiplatelet, statin, they're the 4 standard drugs. So we don't have anything to discuss on those things. But uncomplicated hypertension also, I would recommend that combination. When a beta blocker alone is not enough. I don't know what Soumitra has to say.
Soumitra, your comment
quick
on
comments,
this.
sir. Thank you. 2 quick comments. One is for young, careerist, ambitious patients who are obviously sympathetically overdriven patient walks into your chamber in very high-fi, huffing and puffing with sweating, tachycardia, resting heart rate 90, and said, "Oh, doctor, everything is okay with me," and this and that, that kind of attitude, we are very busy people. Then beta blocker is ideal. They need to calm down. They need to calm down without producing MSD, of course. So you choose a beta blocker carefully. But I am also a bit confused about the European guideline. I actually asked 4 of the guideline makers. They could not answer me. That in the box, they said beta blocker when there are indications, as Dr. Shetty said, post-MI, heart failure, arrhythmia, for pregnancy, and so on. Now, when the beta blocker comes into the picture, what is your fixed dose combination status? Are you still giving RAS blockade plus calcium blockade, or RAS blockade plus diuretic plus the beta blocker? Is a third agent? Or you sacrifice one of those 2, which are mandatory by ESC. When you are giving beta blocker as a compulsion, are you allowed to give one more agent only, or 2 agents you have to give again? They are not clear about it, sir. They have never mentioned it. They just put a box and say beta blocker can come in any stage, but still the fixed dose combination of 2 remains. I don't understand this.
I don't know. Mohan has to answer. See, my real world practice.
So I think Dr. Ray has pointed out a very right thing, but the question arose from one simple fact, that there are R-type hypertensives, which means these people have high renin or normal renin. Yeah. And both these agents, ARB, anti-RAS agents and beta blockers, work through reducing the renin level actually, or are anti-renin agents. Let us not call it reducing renin, but they work through renin mechanism, and hence using them usually is like, marrying brother and sister. It wouldn't be great fun.
Not an ideal
the issue here is, yeah. So Dr. Soumitra Ray is right. If I have to call this resistant hypertension, these people, I probably should be having a diuretic and amlodipine as well on board. And then if there is the blood pressure not controlled, I'll call it. I agree with Dr. Ray completely. But having said that, we also realize that the Indians respond to beta blockers much better than Western world. We got this data from Escort BPLA study, and Dr. Ajay Gupta actually, he was one of the co-authors of that original paper, Escort BPLA of 2003, actually did an analysis of South Asians, which is a metaphor for Indians. And he found that the people who respond to beta blockers are South Asians. Actually, there is a paradoxical rise in blood pressure in black people with beta blockers, but the Indians show a significant decrease in beta blockers. So beta blockers have a role. We do agree, despite the combination may be unusual thing. May not be it may not be 2 + 2 4, but it will make a difference. It may not be the most rational combination, but there are compelling indications. Now let's go to question number 2. The question number 2 is how to manage isolated diastolic hypertension. So Sadan, you and then Dr. Soumitra Ray, how to manage isolated diastolic hypertension.
See, essentially what we call conventionally hypertension is a diastolic hypertension. What we mean by isolated systolic, where diastolic is less than 90. And what we say essential hypertension, essentially we call it a diastolic hypertension. Like if I had to say elderly people, predominantly isolated systolic hypertension, less than, say, younger patient is predominantly, we say, diastolic hypertension. Say maybe age cutoff is 40 or so. And between that 40 to 60, we say both combined systolic and diastolic. So actually speaking, the way we say diastolic hypertension, like a definition of what is the definition of a diastolic hypertension per se. Like you say more than whatever, if you go by the ESC or you go by the ACC guideline, there is no separate, systolic reading given, like whatever is the conventional, whatever I mentioned, stages and grading is okay. Unlike systolic, it's a definite, diastolic less than 90, more than 140 to 159 grade 1 is isolated, beyond 160 grade 2 of isolated. We don't have anything like a grading of a diastolic. So what I would say, diastolic hypertension, nothing but what we talk about essential hypertension. So we have all the drugs what we are giving, that they will all reduce the diastole. Basically, we have to reduce the vascular resistance. Basically, see now we have to consider that the blood pressure is a product of cardiac output and vascular resistance. If we have to reduce the blood pressure, we have to reduce the cardiac output and we have to reduce the vascular resistance. So any drug like what you are giving, though we say beta blocker increases the vascular resistance, is not true. If you have to go by our newer drug like nebivolol, because of the nitric oxide property, they were reducing the vascular resistance. So for that matter, a young diastolic hypertension, my selection of drug will be still drug like beta blocker, which have nebivolol character, because they reduce the vascular resistance because of the nitric oxide mechanism. They reduce the cardiac output. So, the effect of blood pressure lowering is together, two things. So, if it is not, then we can use any drug which will reduce the vascular resistance, like a CCB, or even for that matter, whatever thiazide like diuretics or RAS blocker. So, I don't see a great, thinking in my mind about diastolic. I would be always bothered about how to control isolated systolic. How to control the isolated systolic, that is a more difficult for us, because any drug what we give for systolic will reduce the diastolic. But every drug will produce a diastolic, lowering of the diastolic. So depending upon the age, I would say young, hypertensive, diastolic, I would still give drug like, which are newer beta blocker, or, I may give drug like even the either ACE or ARB. And then if require, combination of CCB with one of the RAS blocker, or maybe, the small dose of drug like, thiazide diuretic. So I don't, in my thinking, I don't think that's a major worry for me. My worry is for isolated systolic hypertension, difficult to treat.
I think this question probably came out because there have been some epidemiologic studies, especially there is a study called GENOA, which has something to do with genetics and epidemiology. And in this study, they found that 10% of the people below the age of 40 years, those who are hypertensive have isolated diastolic hypertension, which means that diastolic blood pressure more than 90 and systolic is less than 140. And that group has never been studied that adequately. Maybe that needs to be studied in detail. But Dr. Ray, what is your opinion about this so-called diastolic hypertension?
Not much difference, sir. There cannot be any difference. Only thing I want to say that by pedigree, it is one generation up than systolic. Because if you see from the history of Paul Wood, from our respected Paul Wood to President Roosevelt, you will see that diastolic hypertension was first recognized as the culprit. And systolic blood pressure as important came after another 12 to 15 years it took to get any importance. So people are treating only diastolic hypertension in the early 70s and early 80s as well. And secondly, as you said, that it is in the younger patient we get the diastolic BP. And as Dr. Shetty said, there are two main mechanisms, cardiac output and vascular resistance. Vascular resistance perhaps is more important for diastolic. So vasodilator perhaps will work better, like calcium channel blocker or RAS blocker, rather than diuretic. If we use beta blocker, we need to use a vasodilating beta blocker, like carvedilol or nebivolol in such cases. That is my personal take.
But
yes,
only one point I want to add more that question is that many times it is important in a young hypertensive. Many times, just going by the systolic reading, you should not, like miss a diagnosis. I agree with you. Diastolic pressure in a young guy, you have to, because the pulse pressure become little narrow, and then a systolic, may not be even 140. It may be this, but diastolic percently more than 90. That you have to keep it in mind. It's a good point that way. Diagnosis: young diastolic, elder isolated systolic, and in between age both combined systolic and diastolic. But it's a good question. Yeah, I agree. Yeah.
So the third question which has come up is, the blood pressure is an aging phenomenon. As age advances, arteriosclerosis takes place.
Correct.
And because of arteriosclerosis, there is actually what you call as rise in systolic blood pressure. Obviously, there is something called Windkessel effect in the aorta. Aorta works as a third chamber. Aorta becomes inelastic. It cannot store the potential energy. So this is diastolic pressure goes up, down, and systolic pressure goes up, arteriosclerosis. Now the question which has been asked is, why shouldn't the threshold of treatment, or for that matter goals, be different in elderly people, say above the age of 65 years, compared to younger people? That is the question.
See, but anyway, I will answer first. See, again, if you go by the sprint trial data, Mohan, even
Yes.
elderly people also. See, the point is that this is something like, I have my own opinion. Like, we need not have aggressive BP control. We need not have aggressive diabetes control. Aggressive, will give more problem. Lipid, we should not get down to low aggressive. This is all, our thinking actually. So long as elderly individual also, if he is able to tolerate even 130/80 blood pressure, is still acceptable. But what the guideline mentioned, that there is a provision that elderly people, unlike the age, whatever cutoff of 65, all the guidelines, which I think for India should be less than say 55 or so, because we are at least 10 years age gap. We should take even any age, so long as they are able to manage, in the sense tolerable BP, multiple risk already, the atherosclerotic cardiovascular disease, or they already got a coronary artery disease, and if they're able to manage 130/80, it's still good. Yeah. I don't think we should go with that fact, at any age, so long as person is agreeable. The point, the guideline just gives us a provision that a patient who is asymptomatic, age cutoff, is one of the factor we can consider. But still, at any age, if you have got, heart failure, you have got the CAD, there is a coronary artery disease or a stroke, like sprint, it has shown even beyond the age of 75, even 130, 120, 80 or whatever the target given is better than even higher level. So I would not, though it is an individualized approach, but grossly speaking, we have to remove from our mind that, that aggression is not, like today only I read an article where lipid, even at the age of 75, beyond that primary prevention lipid therapy in elderly people is, better, we have to give them therapy primary at the age of 75. So I think that age is just a relative factor, I would say. I would not be, as a clinician in the bedside, will be too much. But at the same time, I would see that people should be able to tolerate the BP level. Yeah, that's my, you shouldn't get into lowering of the, because sprint trial has shown very clearly, even elderly population gets benefited. But, like Colin, Soumitra, yeah.
I think that
I will make a comment on that. Yeah.
I think much more important than chronological age is the biological age. And the whole concept is shifting towards the frailty rather than the patient's age. I have seen many of my 90 years old patients are fitter than me, myself. I have got that asthenia. I always feel dizzy and giddy. And if you see us also, I think Dr. Mohan is fittest of us all. Though he's the age-wise, he's the eldest. So it is the frailty index. What is your constitution? That is much more important than your actual age. And this is a generalization that the more the age, you perhaps become more frail. But if you have to go by one parameter, it is frailty. Because if you are too overzealous of sugar or pressure in frail person, you get more hypos, hypotension and hypoglycemia, and you have falls and accidents and so on, which ultimately the net clinical benefit is against you. That is the whole concept. Otherwise, age is is a very loose landmark.
Agree.
No, the reason I think this question arose was based upon sprint. Paul Welton and others have changed the guidelines.
Yeah.
And changing the guidelines so drastically, I think we are swinging, to one extreme. I look at HOPE 3 data. Number of patients is more than what is there in sprint study. These are people where blood pressure reduction only helped if the systolic blood pressure was consistently above 144, 143.5 with a mean of 154. People who had a mean blood pressure 138 did not benefit, they were not harmed. People who had actually a mean pressure of 122 or something and up to 131 systolic blood, they were actually harmed by 25% greater events. Now you may say the recording blood pressure were different in two ways. One is office blood pressure recorded by doctor, another is of course self-monitored blood pressure or in a room separate quite. But the fact remains, we are practicing more like HOPE 3 study. If that is the point, then the data says clearly that up to that number, around 140, 143, you are not benefiting your patients. My point actually is that in elderly people, that sprint guidelines, we may be jumping the gun. I know they have shown in 3.5 years of follow-up that the syncope is not that much, acute kidney injury is not that much, falls are not that much. But, and Dr. Ray is right, that is the frailty which matters, and you have to individualize the treatment.
Correct.
But I think they are getting little too strict for elderly people. That is what my feeling is.
Yeah, Sir, may I have a comment which will be relevant over here?
Please.
I actually asked the first writer of the ACC guideline, sir, why the HOPE was not considered. And he said, Ray, HOPE was never tabled in the guideline. So I said, what does it mean? He said, we are, as a guideliner, we are only supposed to go through the trials or papers which were given on the table. And HOPE paper was never given on the table. I say, who decides that? So that's a separate committee, that their name never come in the front line. And you see, that's why the Milton Packer wrote a fantastic tweet that what is these guidelines? They're nothing. There's so much of underlying background work behind the guidelines, will be surprised to know. Better not to discuss in open forum. So HOPE 3 was never given on the, never considered for ACC guideline. That was a shame. He said, yes, it is a shame, but our hands are tied.
Yeah, and you know, if you do a post hoc analysis of many studies, including INVEST, including TNT with stable coronary artery disease, renal, IDNT, below 130, there is actually potential for harm. There is, not in everybody, but in elderly people. And I thought we need to be a little more liberal in elderly. Thank you. We would actually go to the next question, and I am not able to see the question, so I'll ask Dr. Mithilesh Nayak. Do you have other questions? Dr. Nayak, please.
No, sir. This, yes, sir.
Question,
sir, there is no more question, sir.
Yeah,
okay.
Thank you. In that case, I will give the floor to you to wind it up. It is 1 hour and 23 minutes.
Yes, sir. Yeah, thank you very much, sir, for providing us valuable insight with regards to hypertension management. And I am happy to announce that today we have witnessed more than 1,200 participants, and this is happened just because of you. I would like to thank Dr. Jagdish Mohan, sir, for designing such a great agenda and topics. And I would also like to thank Dr. Soumitra Ray, sir, for dissecting this such an interesting case in a very lucid manner. And I am sure that all the participants like it very much. And I also like to thank Dr. Sadanand Shetty, sir, for dissecting all the guideline and providing the concise message out of all the guidelines. So once again, thank you very much, everyone. And at the outset, I would also like to thank all the participants for their gracious presence. So once again,
So
thank you very much.
can you tell these people when would be the next webinar on hypertension? We have any dates? We have any date in mind?
Yes, sir.
Amit,
Sir, we are
Amit,
Yeah. I think second Saturday of every month, we are going to be
okay,
organizing this practice pulse in hypertension. And
okay, second,
on behalf of Zenith, which is a division of Intas Pharmaceuticals Limited, I would like to offer a vote of thanks. I would like to thank our faculty today, our course director, Professor Dr. B.J.C. Mohan, for designing this program. I would like to thank Professor Sadanan Shetty for informing all the delegates about the guidelines and making the subject very clear to them. And the interesting case Professor Sumitra Kumar has presented today. It was I was also going through the entire presentation. It was really wonderful. So thank you the whole faculty, and I would like to extend thanks to all the delegates. We have crossed 1,300 delegates today, and it's a great number that we have achieved. And I think the kind of presentations which you have gone through, and you would like to come again the second Saturday of every month. So hypertension as a division, we are going to be doing second Saturday of every month, and then third Saturday of every month we have designed a course on endocrinology. So this time on third Saturday, we are having Professor Dr. Shubhankar Chaudhary as the course director for endocrinology course, and we are going to be talking about thyroid function tests. And the first Saturday of every month, we are doing an ECG course. So every Saturday we would like to engage you for this program and for these programs, and we would like you to attend these programs and get the benefit of the excellent faculty that we have in all the programs. And at the outset, I would Professor Sumitra Ray wants to say something. Yeah.
Ray, yeah, not Kumar. That's what I wanted to say.
Oh, sorry, Sumitra Ray. I'm sorry. Yeah. There is always a confusion.
but there is no
Sorry.
confusion. They don't look alike. They don't look alike.
No, my
Therefore,
fault. I apologize.
therefore, you always say only Saumitra. I always say Saumitra. Because Calcutta, you get confused.
Makes life easier.
Yeah. Okay, I think thanks, Amit and Mohan. Thanks, Charles.
Thank you.
Okay.
Thank you.
I would request all the delegates to please
Yeah.
support us for our anti-hypertensive portfolio. We have our Cilnidipine, and Allmark as our Olmesartan as a major brand. So we request you to support us for that. So thank you very much once again to all of you.
Thank you.
Yeah.
Okay. Bye.
Thank you very much, sir.
Bye. See
Thank
you.
you very much, sir. Have a
Thank
good
you,
day.
sir. Thank you. Thanks
Good
very
night,
much.
sir.